So let's take a look at the year in diabetes. We're just going to hit some of the high spots in diabetes. And again, you can ask questions as we go along if you like. That'll get Randy up and he'll get some short bursts of exercise, which we're going to see are important. Okay, so we're going to take a look, including the microbiome. Well, again, this year they said, please identify the high-risk individuals. And anything that causes insulin resistance is high risk. And they said this again because 34% of us are obese and 70% of us are overweight this year, according to the CDC. They also found some more SNPs. We talked about genetic defects. And a couple of the SNPs they found in type 2 diabetes respond very well to 150 minutes of exercise a week. They were pushing that for years, but they said, look, these work. So you want to have 150 minutes of brisk exercise a week. If you can't do brisk, and a lot of my type 2 people can't, okay, walk. But again, you're going to have to walk. Dr. DePetti just showed you for about 4 hours a week. But that's okay. Both of those give you some of the protections we're talking about, and they help these little DNA imperfections, if you want, the SNPs, that cause more people to have diabetes. So they cause you to tip over into diabetes as you get older. The other thing, again, polycystic ovary syndrome, be sure you screen these people when you see them annually because 30% of them are going to get diabetes, at least 30%, and we need to watch them carefully. Again, high triglycerides, low HDL, a marker of insulin resistance. And metabolic syndrome equals pre-diabetes. These people are going to get diabetes. And now the CDC has said that any accredited diabetes education program in your area needs to have a pre-diabetes component. So people always say to me, okay, I found pre-diabetes, what the heck do I do with it? Well, I told them about their diet. This is a concerted program that lasts for several months. And the patients come intermittently, people keep track of them by phone. It's sort of like the Finnish diabetes prevention study. Somebody professionally nags at you to keep you from getting diabetes. And these programs are going to arise because they're mandated by the CDC and the NDA. And you're going to have to, if you're an accredited program, you're going to have to offer this. So they're going to be in your area. Look around for them. They're going to be very helpful in preventing diabetes. And you don't have to do it in your office. You just send them to one of these programs. Some of them are distance. Ours is probably going to be in several remote areas, and part of it is going to be telemedicine. So again, you're going to be able to get your patient into one of these. Because we know that more than 50% of diabetes type 2 can be prevented, but you don't have to do the counseling all yourself anymore. Okay, remember that the degree of overweight is extremely important. We want to start counseling Asians about pre-diabetes and screening for diabetes in Asians with a BMI of 23. You say, oh, not even obese, barely overweight. Yeah, but they are really susceptible to diabetes. Caucasians, again, a BMI of about 30 before you really have to worry too much. They're going to rapidly go into diabetes if they gain a little more weight. How to screen? Same this year. Pre-diabetes is 5.7% hemoglobin A1C to 6.4%. Use the A1C for screening. It's really convenient. Diabetes is 6.5%. When they go over that, into the 6.5%, you want to be sure that you get them therapy for diabetes. It may be diet therapy, but it has to be therapy. You don't want people with 6.5 wandering around because their risk of complications goes up pretty dramatically as they go from 5.7 to 6.5. Remember, it's a laboratory determination, not the finger stick that you do in your office. Okay, again, they told us to emphasize that you really need to screen your high-risk people when they come in at their first prenatal visit. And actually, as you said yesterday, basically, the day before, if your patient is overweight and is contemplating pregnancy, the earlier you find this person who has overt diabetes, the earlier you treat them, the fewer birth defects they're going to have. The person who has the most problems is the person who has diabetes when they become pregnant and you didn't know it, and then you wait till 24 weeks to screen, and suddenly you find that they already have a kid with 6 thumbs. So, no, Just kidding. We really need to screen at the first time you see them, and I screen them when they think they're going to become pregnant. I saw a lady the other day who had a hemoglobin A1C 14, a tongue ring, and several piercings in her ears, and a tattoo, and she said, I think I'd like to become pregnant. I said, please, not yet. Now, people don't always listen to me, but in general, when you see these people who are grossly out of control, or people who have a lot of risk factors, family history, overweight, you need to screen those people when you meet them, because they may become pregnant and not tell you. Okay. Now, what are you going to do about a food plan? I'm going to talk about that a fair amount because of the microbiome. But again, caloric restriction is the key. The ADA says no ideal macronutrient proportions. A lot of people kind of disagree with that. But they're saying that you use a low carbohydrate diet, that's 6 to 8 starch servings a day. Monounsaturated fats need to be high and saturated fats low. That's canola oil, olive oil. So you want to have more complex carbs. You can have carbs, but we like them to be complex. We want them to have a lot of fiber in them. And so 6 to 8 carbs, that's a lot of carbohydrate with fiber, about 25 grams of fiber. And the key here is that they've been doing a lot of studies with how do you get people to lose weight forever. And so what you're going to do is they did a huge study randomizing people into people that we sent to the dietitian. We planned their every diet down to a Brussels sprout a day. We planned everything. And the other people, we just said, okay, you're eating so many calories now, we're going to reduce it by between 250 to 500 calories, depending on what the patient was eating. You know who lost more weight and who had better sustainability of weight loss? The 500 calorie less people, because they got to choose which calories they stopped. And they did much better. So Mediterranean diet, subtract 250 to 500 calories a day, and your patient is off and running. So again, I have that handout in my office so they can just pick it up and go out with it. You can go to MediterraneanDiet.com or .org, depending on whether they want you to pay for their stuff, and actually find that on the internet. Okay, the other thing the ADA said this year is don't just sit. What you need is a short bout of brisk exercise every 30 minutes. The ADA has some vague things. They didn't say we want you to walk around the block. They said a short bout of brisk exercise. So before the middle of this lecture, you want to get up and do a few jumping jacks, please. 30 minutes. So even if you just get up and walk out of your examining room, and I have examining rooms that are on like block-like structures. So I get up out of the examining room after seeing Mr. Smedlap, walk a couple of times around the big block, and I've done it. So again, brisk exercise, not only for your patients, but for you, but short periods of brisk exercise. And more of your patients are willing to do that than saying, go out and walk 30 minutes a day. I've had good luck with that. Okay, so let's talk about your microbiome. Now it's been linked to, an incredible number of diseases, including type 2 diabetes, where there is dysbiosis. And because of that, you get obesity and diabetes and inflammatory factors and vascular disease. And these are all related, although not totally. The microbiome isn't totally responsible for it. You can't blame those little guys in your gut for everything, but certainly they are significant contributors to the problems that we have in patients with obesity and diabetes. So let's take a look. We're going to meet your microbiome. In the first place, the number of your own cells outnumbered 10 to 1 by those little guys in mostly your colon. And the gut is the biggest repository of your microbiome, and it's mostly Bacteroides. Remember that one. So, what's in a healthy gut? Well, diversity. There are more enzymes than you have in your dietary enzymatic collection. Your microbiome has many more enzymes, and in fact contributes about 10 to 15% of your energy intake is generated in your colon by your microbiome. Now, I probably don't need my microbiome to give me 10 to 15% more out of my calories. Most of us don't And so today we're going to talk a little bit about how to change the microbiome so you and your patients don't get all that extra energy out of it. Again, Bacteroides, Proteobacteria, good bacteria, and Firmicutes. Oh, let's think about Firmicutes for a minute, because Firmicutes is one of the bad guys. Okay, so just bearing that in mind. The good bacteria, the bacteria you like, actually help your gut function. They help make the interior of the gut less permeable to bacteria, to inflammatory factors, all those things that are leaking out of the gut that go and irritate the liver and irritate your vasculature. You're better off if you have more Bacteroides that help synthesize the substances that make the gut less permeable to the factors like inflammatory factors or bacteria. They also synthesize vitamins, they degrade bile acids, and of course that lowers your cholesterol. And they produce short-chain fatty acids. And you say, what the heck is a short-chain fatty acid and why do I care? Because short-chain fatty acids improve insulin sensitivity. They signal the liver to decrease gluconeogenesis. One of the big problems with your patients with type 2 diabetes is that their liver makes too much glucose. It doesn't shut off properly because the insulin level isn't adequate in the type 2 diabetic to shut it off. And this helps shut it off. It also decreases leaky gut. Again, these are substrates for the molecules that help the gut be less permeable to to the bacteria and to the inflammatory factors, like HSCRP, for example. Okay, they also decrease vascular inflammation because you have fewer inflammatory factors that leak out of the gut. So, if we look at obesity and we look at diabetes, things are out of balance. And a high-fat, high-sugar diet leads to a gut populated with our enemy, Firmicutes. And it does all those bad things. It gives us more calories out of fiber, it gives us more carbohydrate and more fat absorption, and is one of the major causes of fatty liver in patients with obesity and diabetes. Now, for you people in the pregnancy group, and people who are treating those folks, we used to think that when the fetus pops out, the gut is pretty sterile. Oh, wrong. In the last 2 or 3 years, we found that the fetal gut pops out with a microbiome on board. And whose is it, do you think? Mom, of course, right? Okay, well, if mom eats Hostess Ho-Hos for breakfast with a soda and a peanut butter and jelly sandwich for lunch, what do you think the fetus pops out with? Firmicutes. So, that's a bad start for the world. So do counsel your pregnant moms that they should decrease their carbohydrate intake, increase their fiber intake. You want the little guy or girl to pop out with more Bacteroides and fewer Firmicutes, because it's a hard way to start the day if you already have something that's giving you fatty liver when you're really small. The other thing is, as the toddler develops and interacts with their environment, what do you think constitutes the microbiome? Now, how do they get microbiomes? I mean, they look at your fecal bacterial content. So how do you pick up a lot of these things? Well, you ingest them one way or the other, and fecal transplant occurs in life. Okay, so what do you think the little guy's microbiome is like? The mom, the dad, and the family dog. But when you say yuck, let me tell you that in most families in the United States, probably the microbiome from the family dog would be better than that from mom's individual house one. So, again, think about this when you're counseling your pregnant ladies. You want to make sure they have a decent microbiome to pass on. Okay, so out of balance is a decrease in Bacteroides and a marked decrease in this really good guy. I asked the microbiology chief how to pronounce this. It's Akkermansia muciniphila. And it turns out that this is a bacterium that is very low in people with diabetes, and when you give it to them, they have better diabetes control. So what does this stuff do anyway? It helps you produce a lot of short-chain fatty acids that help your insulin sensitivity. It helps you to stop your leaky gut. You have fewer inflammatory factors. You say, how did I get those inflammatory factors in my gut anyway? You ate red meat, which fosters bacterial overgrowth that actually those bacteria produce inflammatory factors. So again, we're not going to give up eating red meat anytime soon, so we better jolly well get some short-chain fatty acids on board and get more Microbiome eosinophila. Okay, can you reset this thing? Other than interacting with the family dog, right? Your microbiome changes within 24 hours of a new eating habit. And so, again, all these things we've known for years, whole, unprocessed fruits and vegetables give you a healthy gut. Whole grains, nuts, fruits, vegetables can reset metabolism. Where have we heard that? Maybe it's the Mediterranean diet, or as Dr. Petty discussed, the DASH diet. This looks very much like the DASH diet or the Mediterranean diet. So again, we know about this. Tell your patients it really does work. And talking to them just for a few minutes about their microbiome, it's catchy. I'll bet some of you have already thought you won't eat any more cinnamon buns. Okay, everything is down there waiting in your gut. If you feed it, the population increases. If you don't feed it, the population decreases. So you have eaten your whole unprocessed foods for breakfast, then you go out and eat a McDonald's hamburger for, my apologies to McDonald's, a fast food hamburger for lunch. What do you think happens to the microbiome? Right. So it resets within 24 hours, but you can, again, change it back in 24 hours. So it depends on what you eat on a daily basis. Antibiotics really wipe out your microbiome, so try not to use them unless you absolutely have to. And when you wipe out your personal microbiome, other things like Clostridia grow. So again, unnecessary antibiotics for many reasons, you shouldn't use them. Now, can we change the landscape? You bet. You tell your patients how to do this. They can eat prebiotics. Those are foods that lead to the growth of good bacteria that produce short-chain fatty acids. And by the way, stop constipation. Akkermansia eosinophila actually decreases constipation. Okay, so you can use asparagus, onions, garlic, berries, brown beans. There are lots of things in the list. You can get the list off the internet. It runs about 3 or 4 pages. But basically, it's high fiber, low fat, high fiber, or high monounsaturated fat items are what you're going to use. And they know that if you use those prebiotics, you actually reduce your HSCRP significantly. They've done studies in humans. You reduce your glucose. You reduce your ghrelin. And that's the hormone that says, I'm hungry. It comes out about 2 hours after you eat. You increase your gut satiety hormones like PYY. And how does that's one of the things that obesity surgery does. Remember, what it does is it shifts these. After you have obesity surgery, your ghrelin level is lower and your PYY level is higher. And that's true for about, a year to a year and a half. So people lose most of their weight during that time. And then, unfortunately, those hormones get back to normal and people begin to gain their weight again. So it works kind of like obesity surgery without the cost or the scar. Okay, so how about human studies? Well, this is a sad one. Let me put this up. This is one with high fructose corn syrup. And the CDC says, please do not eat high fructose corn syrup. Please avoid that if you can. Please avoid it in your children particularly. We noticed that at Head Start, the consumption of high fructose corn syrup was just overwhelming, and they're trying to just cut back on that a little bit. But this is a study, middle-aged, overweight, obese people, and they 10 weeks, short study, small numbers, very nice science. 15 of the group had glucose. They had 3 sugar-sweetened drinks with each meal, so one for breakfast, one for lunch, one for dinner, basically. And there's 17 people that had high fructose corn syrup and 15 people who had glucose drinks. They had the same number of calories, okay? And they ate whatever else they wanted. And they all gained weight. Well, of course, I'm adding all those calories to your life. But, interestingly, let me put this all up. If you look at the fructose people, where was the weight? The fructose people gained visceral fat. So visceral fat is where it's at. Or what causes metabolic syndrome? Visceral fat. What causes insulin resistance? Visceral fat. So the people who ate the high fructose corn syrup had a heck of a lot more visceral fat accumulation than the people who used the glucose drinks. Glucose drinks, fructose drinks. Oh, not good. How about insulin sensitivity? Well, the people with the glucose drinks, the insulin sensitivity wasn't statistically significantly different. People with the fructose drinks, their insulin sensitivity really took a header there. So it increases intra-abdominal fat and decreases insulin sensitivity. So all in all, high fructose corn syrup is just not a good deal. Now, fructose in fruits and vegetables is coupled with glucose, and so not so much of a problem. So you can eat an apple, you can eat a pear or peach, do they have fructose? You betcha, but they also have glucose. Appears to be the ratio. So some of the soft drink manufacturers have been adding sugar to their high fructose corn syrup. Thank you very much. Okay, so how about probiotics? What are they? They're not like prebiotics. Prebiotics are actual food in most cases. Probiotics are seldom food, but you can have yogurt, and that is a probiotic because it contains active cultures. Expensive yogurt actually contains bifidobacterium, which helps decrease constipation. You can figure out what brand A is here. Less expensive yogurt has lactobacillus, and lactobacillus is helpful. It's one of our good bacteria, but it's not as good as bifidobacteria. So if you're going to use yogurt, you probably want to use like brand S or brand A, which are more expensive but have a better bacterial conformation. The problem is we don't know what's best for you or you. If we did, we could say, oh, Mary Jo, you drink your Bacteroides every morning and you will be thinner. Or Harry Smith, you're going to drink your Akkermansia microphylla every morning and you're going to be better. We don't know that yet because we all have a genetic predisposition to certain components of our microbiome, and we don't know if we can change that. So what the research is doing now is taking a look at taking feces from lean folks. This is a study from Mass General, and randomizing people and putting it into obese folks, or putting a placebo, which is just cinnamon, in case you open the capsules, take a look at it. So you can sign up for that study, it's still enrolling. But if you take, hopefully the placebo group, if you take fecal material from thin mice and put it into fat mice, you lose weight. Okay, so there we go. So metformin actually improves the microbiome and improves your content of Akkermansia muciniphila. I figured if I had to learn to pronounce that, we'd use it several times. Okay, so when to use metformin in preventing diabetes? And we're talking about the microbiome in diabetes prevention and therapy. But again, metformin is useful in both. Now, what's new from the ADA? And that was the really fun part. We'll go through what's new with the ADA. So if we look at the ADA treatment goals, again, they're saying less than 7 is your A1C goal, but you really want to avoid hypoglycemia because now there have been 3 more studies showing that patients over the age of 60 with hypoglycemia more likely to have dementia in the long run. So hypoglycemia is a big risk factor for dementia, particularly in the patients with long-term type 1 diabetes. We all have enough risk factors for dementia without adding hypoglycemia. Blood pressure, I have to just get Dr. Petty on this one because the ADA is vague, but they're sweeping. And so last year they said that you should try, and the 140 over 90 is, where we might want to start. But if your patient had a high risk of stroke, you want their blood pressure to be less than 130 over 80. And this year they said, just try anybody. Everybody should kind of be less than 130 or 80 unless they're going to have side effects. So if your patient doesn't have side effects, go for it. Get them down to less than 130 over 80. And so they're ahead of the game, I think. And again, take one at bedtime. It's a very, very good point you brought up. There's a nice study showing that patients with diabetes taking one of their blood pressure medications before bedtime, they do get better control. Okay, renal disease. The new thing this year, if your patient has an estimated glomerular filtration rate of greater than 60, they don't have stage 3 renal disease. Stage 1 and 2 renal disease, you don't have to stop the metformin or the contrast study. You want to make absolutely sure the patient is well hydrated. As a matter of fact, my patients without renal disease, I say, hey, you're going to get that dye, drink a lot of fluids that day. You want your patient to be well hydrated, but you don't have to stop the metformin. What about the A1C goal? Well, it's still dependent, they say, on the risk factors. If your patient has comorbidities, particularly if they have hypoglycemic unawareness, if they have coronary artery disease, you're going to let the A1C goal, you're going to let it drift up. And last year they didn't pick a number, but this year they picked a number. They said, your patient with a lot of comorbidities, particularly with hypoglycemic unawareness, you're going to want that person to be less than 8. If you look at the Kaiser Permanente data, where they look at the longest lived individuals, they matched it for comorbidity, and they said, okay, what's the A1C that makes you live longest? It turned out to be 7.5. So between 7.5 and 8, we're going to keep those people with the high comorbidities. And we discussed the reason for that is if your hemoglobin A1C is 7, here is your comorbidity rate. So not many complications. If it's 9, look at the complication rate. If it's 8, again, not very much different from 7. So keep your patients between 7 and 8. There's a little difference in the complication rate. There's a big difference in the rate of hypoglycemia. So again, between 7.5 and 8 sounds like a plan. Realistic goals. So dietary recommendations. Well, for type 2 this year, they said please make them aware of the content of their diet. We're making them aware of their microbiome, and it's having a really good effect because they're going to try this stuff out. Okay, bariatric surgery, big change this year. They used to say consider for all of these, but look, it says recommend. If you have type 2 diabetes and a BMI of greater than 40, or if you're Asian and you're 37 and a half, we recommend you get bariatric surgery if we don't have good control. If we're stymied, give up. Don't give massive doses of insulin or U500. Consider bariatric surgery, and they recommend bariatric surgery. Consider for BMI of 30, or Asians, BMI of 27. They're going to screen those people at a BMI of 23. So BMI of 27. We want you to consider bariatric surgery if you're not well controlled. And that's a big change. They're recommending Roux-en-Y bypass. The gastric sleeve hasn't worked as well for remission of diabetes, and the lap band doesn't basically work very much at all. So gastric bypass is what we're going to have. Okay, so let's go on to what kind of meds we're looking at, what's new this year. Remember, type 1 diabetes, we need 24-hour coverage, and we're going to use insulin, we're going to use basal bolus. Type 2, we need medications. We have medications out there that will address insulin resistance, beta and alpha cell dysfunction, renal glucose retention. There's a welter of medicines. And how are we going to choose them? Well, people say to you all the time, just use the medicines you're comfortable with. How often have you heard that? Please don't. What we really need to do is we need to determine the A1C goal. We need to find the problem. 50% of the people who come to my office with uncontrolled diabetes, the problem of where the problem is hasn't been addressed. So you need to find out, is it fasting? Is it post-meal? Is it all the time? When are these blood sugars high? And then choose the medications that are going to reach your A1C goal and address that problem. And if you're uncomfortable with them, consult. Yesterday somebody said, well, when would you consult about thyroid disease or anything else? When you're uncomfortable with the patient, you just don't know what to do next, or you're uncomfortable using the medications that you need for this patient, consult. Okay, medication in type 2 diabetes, well, metformin is the one everybody recommends. And this year, the ADA has said, and to measure the B12 level periodically. I like that. What does that mean? Once a year? Once every 6 months? Probably annually is enough. We don't know which of the people on metformin are going to get B12 deficiency. Well, those people have a bad microbiome. We know that because your microbiome synthesizes some B12. But we otherwise don't know. So annually, for the average bear on metformin, is probably fine. If they have risk factors for B12 deficiency, you may want to measure every 6 months. Okay, so what are we going to do after metformin? Well, the ADA says, gosh, we don't know, but basal insulin is probably reasonable, or bolus insulin before the largest meal if they have a high PM glucose, pre-mixed insulin before breakfast and supper, or your choice of oral agents in any order. They're thorough with aid. Okay, what we're all hoping is that they're going to say soon, as ACE has said, that we need to use GLP-1 receptor agonists as much as we can, because Victoza or liraglutide has been shown to decrease the risk of non-fatal MI, stroke, and death from cardiovascular disease by 13%. Remember, statins do it by 50%, but 13%. And that's in all comers. And empagliflozin, or Jardiance, which is an SGLT2 inhibitor, has reduced CV death in diabetes and patients with diabetes plus known cardiovascular disease. So statistically significantly. So this is probably a class effect. So because empagliflozin, remember, is basically a diuretic. And what it did was to reduce death from congestive heart failure. Well, 30% of patients with diabetes who have cardiovascular disease die from congestive heart failure, and it's progression. So if you give them a diuretic that's an osmotic diuretic, which works no matter what, this is a helper. So again, probably a class effect, but those two have been shown to decrease cardiac death. And not only that, the newest one in the block, lixisenatide, which is a new GLP-1 receptor agonist, also has data that it decreases cardiovascular death. So there's some nice data out there coming out this year. We're all hoping the ADA is going to help us out, because insurance companies routinely do not allow you to use the GLP-1 receptor agonist after metformin. There are only about 4 of them that do that now. So ACE goals: control glucose, avoid hypoglycemia, and avoid weight gain. So ACE has GLP-1 receptor agonists up at the top of their algorithm after metformin. So metformin is suggested initially, and then a GLP-1 receptor agonist is one of your choices that's near the top of the pile. If the patient has an A1C of greater than 7.5, they suggest you start with 2 agents right away. Use metformin plus something else. Don't carry. A1C of greater than 9, they say consider adding insulin to the mix if they're already on agents. If they're not, start with insulin. Don't slow down. And I think that I certainly second Dr. Capetti's thoughts about being aggressive. We know that aggressive changes, aggressive control in early diabetes actually decreases your risk of cardiac death many years down the road. In type 1 diabetes, 27 years down the road, it decreased your mortality from cardiac disease if you had aggressive control when we first met you. So again, aggressive control when we meet pays a lot of dividends down the road. So 3 months at most for a change in medication. Okay, don't forget the sulfonylureas, mainly because the insurance company is loath to pay for a GLP-1 receptor agonist if you haven't tried both metformin and the sulfonylurea. You all fill out this prior authorization forms like I do. But some of the insurance companies will use a GLP-1 receptor agonist after metformin or in addition to metformin, but many of them you have to try sulfonylurea. TZDs and thiazole diones, there are 2 of them, pioglitazone and rosiglitazone, not very helpful. They address post-meal hypoglycemia, and they're cheap. But on the other hand, they also increase congestive heart failure risk, they increase the risk of fractures. Pioglitazone increases the risk of bladder cancer. So all in all, not your favorite drug. Okay, let's take a quick look at GLP-1 receptor agonists. They're good because they suppress glucagon secretion. It goes up after, in type 2 diabetes, after the patient eats. It ought to go down, it's aberrant, and it raises glucose. So that's the one set of drugs, GLP-1 receptor agonists and DPP-4 inhibitors are able to suppress glucagon secretion. They slow gastric emptying, they reduce food intake because they tell your brain you're full. So they're good from a lot of standpoints. But remember, if your patient has gastroparesis and their stomach doesn't empty already, all you give them with either DPP-4 inhibitor or GLP-1 receptor agonist is nausea and vomiting. You don't get much benefit. So remember, again, not to use when you have gastroparesis. GLP-1 receptor agonists reduce post-meal glucose by 0.8 to 1.5%. A really hefty reduction, so that's good. And they generally result in significant weight loss. So, good thoughts. Now, where are you going to use them? This is case one. It's a 56-year-old lady with type 2 diabetes for 9 years and A1C of 8.9. She really needs help. And again, as Dr. Petty was saying, in many offices, she's going to go in and come out with no change in her medication. People are going to say, are you going to follow your diet better? Why are you out of whack? I mean, she's, oh, I ate lemon meringue pie last night. Or, you know, oh, my friends came and I went to the family reunion. And all that's said to that person is, you know, you need to fix up your diet. I could fix up your diet until the last cow came home, and I would never fix an 8.9. So you really need to work on her medication. So fasting glucose over there, pretty good. In my office, that's pretty good. Come in. And what's her A1C goal? Well, she's had type 2 diabetes for 9 years, so she has coronary artery disease statistically. So, you know, I'd settle for 7.5 myself. And so where's the problem here? Well, quite obviously, it's her PM glucose. So it's a post-meal problem. So you say, gosh, maybe I ought to start a basal insulin. Will that do it? No. The basal insulin is not going to fix this problem because you're going to get her down to 64 in the morning, and her PM glucose is still going to be 189. So again, this is a sort of rare case where the problem is a post-meal problem. So you need a post-meal agent. Okay, she has no known complications, but remember that 9 years and statistically significant coronary artery disease. Put that in there because I want to remind you that even if the patient doesn't have known disease, statistically, if you've had type 2 diabetes for more than 5 years and you have an A1C that's more than 7.5, you have coronary artery disease. So remember that person, even if they're asymptomatic. Okay, so these are our choices. TZD, SU, sulfonylurea, GLP-1 receptor agonist, or rapid-acting insulin. Anybody want to make a guess here? Well, we're talking about GLP-1 receptor agonists. We want to lose weight in this patient, or we want to gain weight? Right? Lose weight. GLP-1 receptor agonist. Or you say, well, how come I don't use a DPP-4 inhibitor? Gee, I could do that. I'm pretty comfortable. That's a pill. You take it once a day. Well, unfortunately, the DPP-4 inhibitor prolongs the action of your own GLP-1, but it's nowhere near as good as our GLP-1 receptor agonists. So your A1C is only lowered by about 0.5 to 1% by your DPP-4. So really not as helpful here. But you can use it in renal insufficiency, and it's weight neutral. So where would you use it? Well, this is a perfect, case 2 is a perfectly good place to use your DPP-4 inhibitor. You want small excursions. If your patient's blood sugar goes up more than about 50 to 60 milligram percent after a meal, the DPP-4 inhibitor isn't going to cut it. You're going to have to use a GLP-1 receptor agonist. But this lady's 77 years old. She's had type 2 diabetes for 15 years. And she's had her heart attack. She's had a stroke. She, thank goodness, doesn't have congestive heart failure. Her estimated GFR is 27. Oh, she has stage 4 renal disease and autonomic neuropathy. So she has hypoglycemic unawareness. That goes with autonomic neuropathy. She takes 8 units of Dener in the morning, and her AM glucose is 76 to 96. A1C is 8.4. What's her goal? Less than 8. That's 8. You know? Do I ever want this lady to have hypoglycemia? Never in this lifetime, because it'll be the end of her lifetime, most likely. Okay, so she is a good candidate for DPP-4 inhibitor. She just needs a little lowering of the A1C. Now, her AM glucose is 76 to 96. Anyone want to do anything else for this lady before she leaves your office? You can save a life here. You need to lower the deademer, right? She's on too much. If her AM glucose is 76, her middle of the night glucose, when you have your usual glucose meter, is going to be about 60. And you remember my rule, if you've been here before, your blood sugar should never be less than your age. So, we're going to fix her AM glucose. So if we look at DPP-4 inhibitors, what have you got to do? FDA says you have to discuss the risk of pancreatitis. Well, DPP-4 inhibitors, that's easy. If you have nausea and vomiting, they're oral, not going to be taking. GLP-1 receptor agonist, nausea, vomiting, abdominal pain, stop, and give me a call. And that's really all you have to say to discuss pancreatitis. They say you should also talk to them about thyroid neuroendocrine tumors. Boy, that's a discussion I have with the fellows. I don't know if I can possibly do that in 15 minutes with Mrs. Schmidlap. So again, if you get the symptoms of pancreatitis on board and say, did anyone in your family ever have a thyroid cancer that killed them? That eliminates most everybody, except for the neuroendocrine tumors, because almost nobody dies from that, unfortunately. So that'll help. Okay. So finally here, remember the renal regulation of glucose? No matter how much glucose you get in, it's a small molecule. It all goes into the kidney filtrate. But you have two very efficient systems to haul it back. So the SGLT2 system gets 90% of it back. The SGLT1 system gets the other 10% back. So unfortunately, these systems work when you don't need them to be so efficient. You still get it all back when your glucose, you're still getting it all back here. It's all reabsorbed until your glucose gets to be about, some people 300. So the renal threshold is really high. And so you don't want all that glucose back. If your blood sugar is already 200, you can do without a lot of getting that glucose back. You might just go running on by, right? Well, that's what SGLT2 inhibitors do. They increase the glucose loss in the urine. They increase the A1C by about 0.8 to 1.5%, and they increase calorie loss by about the same as one large cookie a day, about 300 calories. So you'll lose about 300 calories out in the urine, but that's, if you eat the large cookie, you can't come out even. They increase sodium loss, so your blood pressure goes down. So all in all, they sound like a really good game. And they have rare hypoglycemia because remember the SGLT1 system is still there and it's going to haul back glucose. So you can use these very nicely and they have a lot of good effects. They also appear to decrease the rate of renal decline. So you want to keep those kidneys as long as you can in pretty good shape. They do that too. There's some studies out this last year. So, what are the adverse effects? Well, obviously, your urine is full of glucose. And so increased urinary glucose gives you a place to breed bacteria that arose from your gut, came out the back end. And so you get increased urinary tract infections, you get increased fungal infections, and you get osmotic diuresis. That means that even if you're prune-like state, you're going to keep diuresing. And that glucose just takes water out with it until you are totally dehydrated, have renal insufficiency, acute renal damage, and diabetic ketoacidosis, and it will still continue to take the fluid out. So you got to be very careful. These people truly need to drink a lot of water. That's 2 or 3 liters a day. Thank you very much in Texas in the heat. 2 to 3 liters. Time to tell you my story about the oil guy, because he worked on an oil rig. So he was out in Houston, he was out in the water. So they went out in the morning, and they were supposed to take all their lunch and their water and all this stuff with them. Well, did he do that? No, one day he forgot his lunch. I'm a perfectly normal person with type 2 diabetes, on SGLT2 inhibitors, very healthy, had normal creatinine, came back at the end of the day, had nothing So his friends took him to the nearest ED. He had a creatinine of 6, that's 6.0, and he had DKA. Oh my, well, that's what one day without water will do to you on an SGLT2 inhibitor. So you need water, you need carbohydrate, and you need to be liberal with the water. Also, there's now a black box warning on canagliflozin. I think it was put on last week, but we know it's coming out. As an FDA warning against amputation, they're saying that if you are on canagliflozin, which is Invokana, but probably this is a class effect too, you have a higher incidence of amputation, particularly of the toes, the peripheral digits in the lower extremity, they said, the toes. Okay, why would that be? That's really odd. Well, not really, because if you dehydrate someone with peripheral arterial disease, what happens? Right, they don't get those 2 red cells to their big toe every day, and so they're going to lose their big toe. Okay. Lots of water, really. Okay. Now, who are you going to use this in? Case 3 is a 45-year-old female with type 2 diabetes. She's had it for 3 years, so she doesn't have statistically any coronary artery disease, no matter how badly controlled she is. She has a normal exam. She has no known complications. She has a normal blood pressure, 130/80. BMI is 34. A1C is 8. What's her A1C goal? Less than 7. I mean, there's nothing wrong with this lady except diabetes, so you really want to get her down to less than 7. So already taking maximum metformin, you want to avoid hypoglycemia, avoid weight gain. Her glucose in the morning is 120 to 140, which is plus minus, and her glucose in the afternoon is 180 to 220. So where's the problem? She has a post-meal problem. So SGLT2 inhibitors are good at that, and so she fit an SGLT2 inhibitor. Okay, so let's take a quick look at insulins. Nothing much new this year. Degludec has a couple of new studies. That's Tresiba, and Glargine U300, which is Toujeo, has a couple of things. But other than that, insulin is pretty much the same as it was last year. No exciting new developments. Inhaled powdered insulin is basically gone from the market because nobody used it. Gone. Okay, so remember just briefly, insulin, deciding the dose. It's weight-based, and it's based, therefore, on insulin resistance. So it's weight-based, it's insulin resistance-based. So in type 1 diabetes, your dose is going to be smaller because they have less insulin resistance. They usually are lower weight. As they get a little chubbier, you're going to want to go up from 0.25 to 0.5 units per kg per day. With type 2 diabetes, about 0.5 units to 1 unit per kg per day. These are starting doses. We're going to have people on other than the starting doses, but this is a good, safe starting dose. Now, where in those ranges are you going to be? We just said the chubby type 1 is going to be toward the top. If you have renal insufficiency, you're going to be toward the lower end of that range for starting dose. If you have hypoglycemic unawareness, lower of the range. Cardiovascular disease, we have risk factors. You're going to be at the lower end of that dose when you start. If you don't, we can mosey up with a higher dose. ACE also, remember, says the higher the A1C, the higher the dose, barring these other complications on the bottom of the slide. Okay, so we're going to add insulin to type 2 diabetes. Remember, look at these oral agents. I see people coming in on 2 kinds of insulin and 4 oral agents. I'm just the co-pays are staggering here. So remember that you want to retain metformin, and if you have sulfonylureas on board, particularly if the patient's had type 2 diabetes for more than 5 years, then you probably want to get rid of them unless they are the only coverage you have post-meal. If you're just using basal insulin, you've got to keep something for the post-meal glucose. Sulfonylureas are fine. Insurance companies pay for them. They're not dangerous. TZDs, yes, I'd probably get rid of those because they cause fluid retention and you can get CHF in people to whom you add particularly these new concentrated insulins. You get CHF with the TZDs, so I would get rid of them. Okay, so you're going to retain your GLP-1 receptor agonists, your DPP-4 inhibitors, and your SGLT2 inhibitors. They work very nicely with insulin. Remember, drugs aren't approved by the FDA in combination anymore. You can use anything you like that's approved for diabetes type 2. Any of those you want. Concentrated insulins that we're talking about, the differences are that the peak is blunted and the duration is prolonged. And if you remember that, you're not going to get into trouble with concentrated insulins. They have more constant levels. Tresiba or Degludec, remember, is peakless. There's less nocturnal hypoglycemia because they are peakless. And you cause nocturnal hypoglycemia if you try hard. But basically, less nocturnal hypoglycemia. They come in easy-to-use pens. And remember, there are side effects that you didn't even consider with these other insulins. There's hypokalemia. Remember how we used to treat hyperkalemia in the old days, ran an insulin? There's fluid retention. You can cause congestive failure with these new insulins, and the patient has a lower ejection fraction because of the significant fluid retention. Remember, insulin causes the kidney to save salt. So it does when you put people on these newer insulins. And they are, of course, also expensive. Some of my patients are paying like $500 for 2 pens, these concentrated insulins. Very, very expensive. Make sure the insurance company pays for it. Okay, so as we round up here, this is what's really new. Came out about, a month ago, and now these are available in our area. This is a 33-year-old lady with type 2 diabetes for 5 years. Her A1C is 12. Oh, what's her goal? No complications. Less than 7. We've got a long way to go here. We're only going to make that with insulin or insulin combination therapy because we're never going to make that with just one agent. Where is the problem? Well, she says, my glucose is always over 300, so why check? It's sort of everywhere, isn't it? Yes. Okay, so I always say to this group, please, once a day, vary the time, that's all I need. Which brings us to how often are you going to have your patients check their sugar? Only where they needed to make a decision about medication. You don't want them to check it 15 times a day. And if necessary, only where you need it to make a decision. I only need it once a day if you just vary the time. Okay, so she needs basal bolus insulin. I mean, really, yes. But she won't take it. Do we have something for her? No. She can use the Degludec-liraglutide combination. Remember, that is Tresiba and Victoza. Or she can use glargine and lixisenatide, which is Lantus, and their new GLP-1 receptor agonist, Nina. So, they come in 1 pen, each one. So, Ideglira, or Zoltofi, again, reduces A1C more than either Degludec or liraglutide. It's more effective than either of the components. It's really easy to use, and I have several patients on it. It surely works. But I have to point out to you, Zoltofi, or maybe it's Zoltofi. At any rate, they're sitting around this table, and there are about 25 people on, and they're saying, what do we call this in the United States? And in Europe, we call it Ideglira, which seems to be reasonably good. So what are we going to call it in the United States? Some guy out at the end says, let's call it Zoltofi. Yeah. Have you ever wondered what that person's going to name their children? Okay, the other one is Solica. Oh, much better, but that's Lixlan. And again, that's glargine and lixisenatide, and works very well. Look, 55% of the patients in this study had a hemoglobin A1C of less than 7, as opposed to on just glargine, only 30% did. Because you've got to treat the post-meal glucose. And so when a patient only takes 1 injection a day, this treats basal and post-meal. Treats all of the above, and these people do very well. And as I said, the people I have on it have very few side effects. You have to talk again about pancreatitis. Remember, nausea, vomiting, abdominal pain, stop this, give me a ring. But you really, these really work quite nicely, so you might want to add them to your own material. Okay, in summary, we're still going to identify those high-risk patients. And now we're going to treat prediabetes. So if you have a prediabetes course in your area, be sure to send your patients with prediabetes to it. For one thing, we need the money. But in addition, it's hard to run. But really, it's going to be a big benefit for the patient because it's a long-term course that gets back to them, keeps them in touch, engages them. It's a very interactive course, and it helps them lose weight. Dietary therapy is imperative. Be sure you take home what we talked about and fix the microbiome, lower carbohydrate, actually more fiber. And the newest diet, has anybody told you about the MAP2 diet? Anybody in your patients using that? How old my patients are? It was named after a guy named Mario Piziak, Italian. And so he just used the first two initials, the first two letters of his first name and his last name, and then used it in type 2 diabetes. It actually lowers glucose. And the thing that it has is it's high fiber, it's nuts and berries, there's no animal protein, making it incredibly unpopular in Texas. And so no animal protein, but mostly high fiber, and the only fat is monounsaturated fat. It sounds like the Ornish diet. It will undoubtedly work to lower your HSCRP and make you sick. With Danny tried it, get terrible diarrhea. You have to titrate your fiber up when you're raising the fiber. Okay, so talk to your patients about a food plan. Talk to one that will fix their microbiome. Talk to them about what they want. This isn't Kaiser Permanente. We can just talk to the patients about what they'd like to do and kind of take that into consideration. And really, when you're talking to patients about type 2 diabetes, always, no matter what the visit is coming from, they're coming for type 2 diabetes, no matter what the main focus of your visit is, do not let them leave the office without discussing prevention of cardiovascular disease. Because is the type 2 diabetes going to kill them? Of course not. I have patients for 30 years who have type 2 diabetes. What's going to get them is cardiac disease. Okay, so now we have questions. I've got those questions. Here we go. All right, question 1. Your patient with type 2. Okay, you got it already. There we go. A patient with type 2 diabetes doesn't hallucinate more than one injection, and both the fasting glucose and post-meal elevated. You tell her, I dig lyra. 2 people thought it isn't going to work. It'll work. Okay. The role of the microbiome. Yes or no, the microbiome influences the utilization of food in the gut. Very good, everyone got that right. The role of the microbiome. SGLT2 inhibitors increase glucose in the serum, decrease glucose in the urine, and increase blood pressure and can cause decay. We all got that. But one of us should do this, not both.
Yeah. 4 is not working. Go ahead and go to 5.
Okay, I'll go right to 5. Which of the following medications for diabetes reduces death from heart attack? There you go. Liraglutide. Oh, sitagliptin is Januvia. You are very close. This is Jardian. This is empagliflozin. Okay, is that it?
That's it.
Okay, are there any questions from the audience? You're all anxious to get to the beach, except Dr. Lake.
I have some questions about prediabetes, prediabetes seems to be kind of the big focus these days. Some controversy about if or when to start metformin on prediabetes, and then also along the same lines, if we're going to treat prediabetes like diabetes, at what point would you add an ACE inhibitor or a statin?
Very good questions. Well, prediabetes, when would you start metformin? Well, the ADA guidelines suggest that metformin is helpful in virtually everyone. They used to suggest you should start lifestyle and use it for 3 months or until the patient really failed at lifestyle. Last year they just said, in patients in whom you consider it efficacious, start metformin. Vague, but all-encompassing. So, I'm sorry, what was the other question? I had a short memory.
So, and again, if the idea is really statins and ACE inhibitors too, I mean, for us, our EMR, it actually automatically populates the prediabetes and diabetes are the same, so it's automatically asking us, are they on an ACE or an ARB? Are they on a statin?
I love it. Right, okay, well, now that the ADA has changed this year, if you have diabetes and hypertension, they used to say you must use an ACE or an ARB. But this year they said only if you have proteinuria do you have to use an ACE or an ARB, otherwise just follow the GNCA guidelines. So you don't have to start the ACE or the ARB if they have hypertension, but vast majority of us do. So only in hypertension where you have proteinuria do you need to start the ACE or the ARB. Is it required? But otherwise not. But again, most people are starting with ACE or an ARB. How about a statin? Well, virtually everyone with type 2 diabetes has enough risk factors for a statin because one of the risk factors is obesity. And so you're going to use a moderate dose statin in the vast majority of patients with type 2 diabetes. There are a few thin people that come to my office. I maybe have one person every 5 months that shouldn't be on a statin and has type 2 diabetes. So virtually, yes, everyone. Pre-diabetes. Again, what are their risk factors? And you're going to use the American Heart Association criteria for pre-diabetes. You can put them in that calculator that you're going to have tomorrow morning, and you can actually use that to predict. No. Just don't say they have diabetes at all. Just leave out diabetes. You're going to take all their other risk factors. In most endocrinologists are starting patients with pre-diabetes on a statin because of the risk factor profile. In fact, the ADA does not use the AHA calculator. They say, look at the risk factors. If they're obese, if they have hypertension, if they smoke, if they have microalbuminuria, that's a correlate, not a risk factor. If they have an LDL of 100 or more, that's what the ADA says you should use. And if it's in pre-diabetes, they suggest you go right ahead. Okay.
I'm sorry.
The faculty is asking questions. Is that allowed?
Yes, it's encouraged.
All right.
Thank
When
you.
it's outside our specialty, it should be allowed. Why are there ads that pop up on Google and such informative places such as that tell us that prescribing metformin is so bad? What is out there about metformin, and how do I reply to patients? I've seen ads that keep popping up. Don't prescribe metformin.
Metformin, the vitamin deficiency producing medication. That's mainly the B12 problem, and so if you screen annually for B12, you're finding other things. You can get dehydrated and get diarrhea on metformin. It's about 20% of people have significant diarrhea. And so there have been little pop-ups saying you can get acute renal injury on metformin due to dehydration. You're showing your patients that if they have diarrhea, you will get them off metformin. So the other thing is that a lot of people feel that metformin causes renal injury, but it doesn't cause renal injury unless you have dehydration. So what you want to make sure is your patients on metformin are not dehydrated. And when they have renal insufficiency, remember you can use it down to 3, as long as you're stage 3 or higher. Lower, you don't want to use it stage 4 and 5 renal disease. Stage 3, you can use it down to an estimated GFR of 30. And it's okay to use 1,000 milligrams rather than 2,000 as your maximum dose. But you need good hydration. And if you get dehydrated, yes, you can get renal insufficiency. You get dehydrated, period, and you have stage 3 disease, you may well get acute renal injury. So I think it's the renal injury, the diarrhea, and the B12 are the ones that I've seen just popping up, or people bring them in. Now they used to bring them in as a piece of paper. Now they bring an iPhone. I just screen it and say, I'm going to blow this up, doctor. I want to know what's wrong with my medicine. Yes. Oh, speaking of that, speaking of blowing up, should we stop? Oh, point of care A1C testing. Oh, never in this lifetime. They're saying that point of care A1C testing is not as accurate as doing it in the lab. That's fostered by the lab. No, they need to make a buck. But really, point of care testing, you're using serial determinations. You're not using it to decide whether or not to start meds. You're not using it to decide whether or not you have diabetes. You're using it when Mary Jo comes back from a follow-up visit and you want to know what happened. Point of care testing is invaluable to help you keep track. Is the hemoglobin A1C always accurate? No. If you have people with high red cell turnover, if you have people with a hemoglobin A1C of less than hemoglobin less than 10, it's not accurate. But really, if they stop point of care testing, endocrinologists wouldn't make any money. Next.
Question about plant-based diets. Have you seen What the Health yet?
What the?
It's called What the Health. It's one of those, what you call it?
Videos?
Well, it's a video, a documentary about plant-based diets, like fork over knives, things like that.
Right. I have not seen that, although there has been a huge study, a 12-year study on populations of these plant-based diets. They have less breast cancer, they live longer. Again, plant-based protein is really much better for you. I couldn't say that in Texas because they throw, rotten fiber-filled fruit at me. Would you like to enlighten us about that?
No, I think it'd be worth watching. It's just interesting how the pharmaceutical industry and some of the McDonald's, the beef industry, and so forth manipulate Susan G. Komen Foundation, how they give significant amounts of money to American Cancer Society and so forth. So some of the diets that they recommend on their websites don't really benefit the patients. The recipes on the ADA website and so forth don't benefit the patients in terms of heart disease and so forth.
Well, very true. The ADA has not been as spiffy with heart disease as the American Heart, for sure.